بسم الله والصلاة والسلام على رسول الله. أنا علياء الجمري، هتكلم معاكم الليلة في الكورس بتاع البيدياتريك دنتستري تبع الدنتال سكول إيكو عن الفارماكولوجيكال مانجمنت of the pediatric dental patients. So the outline of this course or for this lecture specifically, we will get an introduction and then we'll speak about sedation regarding definition, indications and contraindication. And then we'll speak about preparation and drug administration in regards to dental sedation. And we will take a little bit to describe in details the clinical technique for how to do nitrous oxide clinical sedation. And then for the next lecture, inshallah, we'll speak about the dental general anesthesia in terms of definition, indications, and contraindication. So my learning objectives from this course is, by the end of this lecture or this course, the student should be able to define sedation and general anesthesia, discuss the indication and contraindication of sedation and general anesthesia, to know how to prepare a child and the parent for sedation and general anesthesia, and to list the route and medications commonly used for sedation and general anesthesia in the context of pediatric dentistry. So, the need for adequate pain management is the right for the patient, and it's a crucial issue in the field of clinical dentistry, and this is even more challenging mission in case of children. When the clinician is faced with the treatment of uncooperative patients, such as very young infant, a teenager with extreme afraid of injection, a mentally retarded individual, or other challenging situation, this is considered as a very big challenge to provide a care that is safe and effective. So we are speaking about, we want to do a dental treatment and we want this treatment to be safe and effective at the same way. And although the non-pharmacological technique or non-pharmacological child management technique, such as tell, show, and do, positive reinforcement, desensitization, modeling, shaping, all these techniques are very effective and we usually use them in a daily basis. However, sometimes there is a need to combine this non-pharmacological technique with pharmacological technique. So if we want to put a base here, we would say that even if we are using a pharmacological technique, we will be combining it with non-pharmacological technique, except for the general anesthesia. The general anesthesia, it's only pharmacological. But for all other, the sedation technique, we will combine it with non-pharmacological technique. So before you know the sedation and general anesthesia very well, I will advise you to listen to the lecture of the non-pharmacological technique and to know it very well. So pharmacological management of pediatric dental patient can be divided broadly into two categories. We have sedation and general anesthesia. In the first lecture, we will speak about sedation, and in the second lecture, we will speak about general anesthesia. So let's start the journey of sedation and we will take it step by step. We will go through definition, indications, and contraindication. So what is sedation? It's a medically controlled state of depressed consciousness. And when I said medically controlled state of depressed consciousness, because it's not like a coma. Here in the sedation, that it's the medical team who put the child in this depressed consciousness. And the rest of the definition, it's a very long definition, but the idea of it that we want to differentiate the sedation from the general anesthesia. And here what makes sedation special, that even that the child is in a state of depressed consciousness, this allows for protective reflexes to be maintained. So the patient has the ability to maintain patent airway independently and continuously. And the patient can have appropriate response to physical stimulus or verbal command. So usually when I speak about sedation, the patient can have a patent airway and should respond appropriately to physical and verbal command. What are the goals of doing sedation to a pediatric patient? We want to guard the patient's safety. We want to minimize the discomfort and pain. We want to minimize the psychological trauma that sometimes accompany the dental treatment. And we want to maximize amnesia. We want to allow successful completion of treatment, and we want to ensure the best quality of care. And then when I speak about sedation, we should know that there is levels of sedation, or sometimes we call it spectrum of sedation. So it's not only like one type of sedation. We have minimum sedation, where the patient can respond to verbal stimuli. So the patient is sedated, but it's to very minimum level. And then we have the moderate sedation, where the patient responds to verbal or tactile stimuli. And then we have deep sedation, where the patient responds only after repeated or painful stimuli. And maybe you can guess what we're going to have after deep sedation. We will have general anesthesia. So we can see here in this picture, the spectrum of sedation. We start with minimum sedation and moderate sedation, they are together. And then we have deep sedation and general anesthesia. And we should know that if we are not very well prepared and we are not dealing with sedation with caution, the patient can move from one stage to another stage unintentionally. So maybe my intention is to do moderate sedation, but then the patient will go to deep sedation. And that's why I should be very careful. So let's speak about how can I determine if this child needs sedation or not. If I want to decide whether to use sedation or not, there is several factors that I should integrate them together. I'm not going to look for a single factor. So what are these factors? The risk involved with sedation compared to other techniques. Other techniques, I mean non-pharmacological technique and general anesthesia. I should look at the cost and venue issue, if the parents can afford the sedation, and if my venue or my clinic is well prepared for sedation. I should look at the extent of the dental treatment, because we should understand very well that sedation is not for every treatment plan. So if my treatment plan is very extensive, or I want to do a full oral rehabilitation, I should go for general anesthesia and not sedation, okay? And I should look at practitioner training and experience, if this practitioner has an experience, for example, in doing nitrous oxide sedation or not. And I should look at parental expectation, what are they expecting? So if they are expecting for the full dental treatment to be completed in a single visit, I should look at general anesthesia. So parent expectation is very important point to be discussed. And the nature of child cognitive and emotional needs, and we're going to speak about this in a little bit in more detail. So from all these considerations, what are the indications of doing dental sedation? If the child has dental anxiety or phobia, if there is behavioral difficulties, especially like previous traumatic experience, the child has previous extraction, it was very traumatic. So now he needs only single extraction, but he has a traumatic experience and he will not tolerate the injection. At this point, I can do one sort of any type of sedation. Emergency treatment, in so many cases, we use sedation in emergency. Medical conditions affecting the patient's ability to cooperate. For example, the patient has learning difficulties, so I cannot only treat the patient with non-pharmacological technique, I can use pharmacological techniques like sedation, or medical condition potentially aggravated by stress. For example, if the patient has asthma, and I'm expecting that he will not tolerate the local anesthesia, so I can combine it with sedation. Or psychosocial indication like uncontrolled reaching or gag, like for example, severe gag reflex, I can use sedation. So what are the contraindications for the sedation? If the child is under 1 year old, I cannot use sedation. This child should be sent to general anesthesia. Any child below 1 year, I cannot treat it with sedation. And if the child weight is less than 15 kilograms, also here in this case, I cannot use intravenous sedation. Also, I should go for general anesthesia. Medical condition affecting operation, like severe learning difficulties, severely ill patients. For those patients, it's better to go for general anesthesia and not for sedation. And there is also dental contraindication, as we mentioned before. If I have lengthy procedure or very difficult procedure, it's better to be managed under general anesthesia. And why I'm saying this? Because one of the major differences between general anesthesia and sedation is that in sedation, the airway are not protected, okay? And there is no throat pack, and there is no, the patient is not intubated. So there is a great risk of aspiration. And that's why I cannot do lengthy and difficult procedure. I cannot do like 8 pulp therapy and stainless steel crowns, or I cannot do extensive extraction. Like, for example, I want to do 16 extractions sometime. For these cases, sedation is contraindicated. I have to go to general anesthesia because the child will be intubated, and I can have a throat bag. The airway are fully protected, and I can do whatever I want in general anesthesia. So this are the contraindication for sedation. So now we decided that this patient is indicated for sedation. How can I prepare my patient? And what are the drugs that I can use, and how can I administer these drugs? So let's look at these points. So starting with patient assessment, I have to look at the history and do a very proper examination. I have to look at the ASA classification, and we will look at it in a minute. And just put in your mind, for the ASA classification, I can only treat patient class 1 and 2 in sedation. From class 3 and above, I have to go for general anesthesia. Also, I have to look at the ASA recommendation for fasting, and we will state it now. And of course, the parent should sign a sedation consent. We cannot take a verbal consent for sedation. It should be written consent. And it should be, of course, informed consent with all the elements of the informed consent, and the patient and the parents should understand the consent before signing. So if I want to ensure that I'm doing safe sedation, I should do a careful evaluation for the airway, should make sure there is no enlarged tonsil or an anatomical abnormality. I should have a good understanding about the pharmacodynamics and pharmacokinetics effect of the drug I'm using. I should have appropriately sized airway equipment and venous access emergency drug available. I should have intraoperative monitoring, and we're going to speak about monitoring. And we should, of course, have a properly equipped staff in the recovery area, not only in the dental clinic or in the operation room. We should have them also in the recovery area. And we should have a proper discharge criteria, and with instruction written, and we can state them also in a minute. So what are the ASA recommendations for fasting? That the child should fast from clear fluid for 2 hours, from breast milk for 4 hours, and from formula feeds and solid food for 6 hours. I have been to hospital where they recommend 8 hours fasting, but according to the ASA recommendation, you're going to have the rule of 2, 4, and 6. However, in an emergency situation where fasting, because you remember that we mentioned in the indication that sometimes we use sedation for emergency treatment, for example, after extensive orificial trauma. So an emergency situation where fasting cannot be assured and the procedure cannot be postponed, simple sedation should be used. And what I mean by simple sedation, that it should be minimum sedation, and it should be with a single drug. I should not combine 2 drugs together. Whenever I combine drugs together, this is no longer a simple sedation, only 1 drug. And if it's unsuitable, like if simple sedation or minimum sedation is unsuitable to do the required extensive treatment for the emergency situation, I should go for general anesthesia with rapid sequence induction. In this case, it's better to go for general anesthesia with anesthesiologist with a good experience, other than going with, for example, IV sedation with combined drug, and you are an emergency and the child is not fasting. And for sure, in every emergency situation, you should weigh your risk versus benefits before making any clinical decision. And here is the ASA classification, where we said that we're only going to treat class 1 and class 2. So class 1 is a normal healthy child, and class 2 is a child with a mild systemic disease. Mild systemic disease. For example, the child is asthmatic, but the asthma is well controlled, and he has never been to the emergency room for asthmatic attack for the last 3 years, for example. So this is a mild systemic disease. The same with the diabetes. If the child is well controlled and he has no hypoglycemia or any hyperglycemic coma or any complication of diabetes for the last 1-2 years, so it's a mild systemic well-controlled disease, I can go for sedation. But if the child is class 3 or 4 or 5 or 6, like for example, severe systemic disease and life-threatening condition, or not expected surviving without operation, or declared brain dead, or all this situation, I cannot go for sedation. Okay, so now we have cleared everything and we did our clinical examination and everything is fine, and we decided, okay, let's do the sedation. So now there are 2 questions very important that we should ask and we should decide on. Which drug we're going to use and by which route we're going to administer this drug. And there is so many drugs and route of administration, but I'm going to give you just like a brief idea about what's happening here. So regarding the routes of administration, we can administer the sedative agent either by inhalation or by intravenous or orally or intranasally. Or even this is the most common, but also there is sublingual, there is rectal, there is intramuscular. All these are route of administration. And then we come to the drug. The most famous one is the midazolam, ketamine, propofol, and nitrous oxide. But there is many other drugs. Some of them are just historical and there are no longer in use, and some of them are used. But what is the special things about sedation that even when speaking about the routes, you can combine more than one route. Like you can use intravenous with inhalation, or you can use oral with intravenous, or you can use inhalation with intranasal. And the same thing's going with drug. You can combine 2 drugs together. For example, you can give midazolam with nitrous oxide, and you can give ketamine with propofol, and they call it ketofol. So you can combine the drugs and you can combine the routes of administration. And this is where we're going out of simple sedation. So whenever you combine techniques or drug, you are out of simple sedation. And for today, I'm going to focus on the part of routes of administration. We're going to explain it and we look at each route and the advantage, disadvantage of each one. Regarding the drugs, usually as a dentist, you should have like a general knowledge about the drugs, but calculating the dosage and preparing it in the clinic, usually you're going to have anesthesiologist with you or sedationist who are going to prepare the drugs for you or calculate the drugs. But you should have a general idea. But regarding the routes of administration, you should know it very well because you are the one who is going to decide which route you would like to do. So for example, you're going to say, this patient, I would like to treat it with nitrous oxide sedation, or I will go for IV sedation. This will depend on the advantage and disadvantage and indication for each patient. So starting with inhalation sedation, it's the most commonly used technique. It's considered the safest and the most effective and the easiest techniques to deliver sedative drug. It's not the most effective, but let's stick to it's safe, effective, and easy. It's the safest and the easiest, but not the most effective one. And the agent used with the nitrous oxide sedation is with this inhalation sedation is the nitrous oxide gas. And usually we mix it with oxygen. So we don't use pure nitrous oxide gas. It's useful for decreasing mild level of anxiety because it's a simple sedation and it can produce only minimum level of sedation. So what are the advantages? Most reliable route in terms of onset and recovery, the degree of anxiety found to be lower in subsequent visit after the sedation because they call it the laughing gas. So usually the patient experience with the nitrous oxide is very pleasant in most of the time because some of children, they like vomit and they have nausea. It's some of the side effects, but most of them, they will laugh. So at the end of the session, they will be happy. And at the subsequent visit, they will only remember that they were happy during the last visit. And usually at the subsequent visit, if you want to do something very minimum, you can do it without the nitrous oxide sedation. So it's a very good because it's usually improve the level of cooperation of children. However, it's reduce only minimum sedation. And why we put this as an advantage and not disadvantage? Because that's guarantee the safety. If we are, you remember the spectrum. So if we are at the beginning only doing minimum sedation, there is no any chance that we can go to deep sedation or to general anesthesia, for example. And that's why it is the safest sedation. What are the disadvantages? That it can only use in cooperative children. And usually we say children above 5 years. Why? Because, and we're going to see later on in the clinical technique, that the child should put the nasal hood. And it's a little bit noisy. So if the child is very young, or if the child is extremely uncooperative, usually they refuse the mask. So this is one of the disadvantages of the nitrous oxide, that it can only be used if the child is cooperative. But he's usually not very cooperative to tolerate the injection without anything. So he's cooperative to sit on the chair, to put a nasal hood, to open his mouth for a mirror, but he will not tolerate the injection. And that's why I'm using nitrous oxide. Okay, so this is one of the disadvantages. And the other thing why I can only use it above the age of 5 to 6, because children younger than that, they will not understand that I'm going to put a nasal hood and you should breathe from your nose and you should keep your mouth open without breathing. So what they usually do at the age of 3 or 4, when we try it with them, you put the nasal hood and you will ask the child to breathe from nose, but what they're going to do, they'll open their mouth and they will take the nitrous oxide and they will exhale it from their mouth. So no one is getting the nitrous oxide other than you and the nurse. The child is not getting anything of it. Or they breathe from their mouth. They will open the mouth and breathe from their mouth. And that's why it's not indicated, or it's not useful in very young children or uncooperative children. And that will take us to the second disadvantage, that we also consider it as a contraindication of nitrous oxide, that we cannot use it in pre-cooperative children or patient with inflammation in the sinus, or patient with ear infection, or psychotic patient, because sometimes it gives hallucination. Okay? And then the second route of administration is intravenous sedation. So intravenous technique is commonly used by injection, and usually either single drug to be simple or multiple combined complex sedation. The success of intravenous sedation is directly related to titration. So it's not acceptable in intravenous sedation to give only one shot and that's it. Usually we give very small shot and we wait and we see how the child reacts. And then if we feel that the child is not enough sedated, we will give another shot of intravenous sedation. So we do titration. And this is one of the main advantages of the intravenous sedation. So the advantage that it can be titrated, and the onset of action is very rapid. So the moment you inject the drug intravenously, within 30 seconds, the child's eyes will drop. The onset of action is very rapid. The maximum level of sedation is deeper than with the oral or inhalation sedation. So it can give a deeper level of sedation. This is good in terms of the thing that I can do in the operation, but it's also could be considered as a disadvantage, as we're going to see. And the gag reflex is highly diminished, and this is a good advantage. However, the disadvantages are the needle itself for children. It's very difficult sometimes, because sometimes the child has already an anxiety and phobia, so they will not tolerate to have an intravenous injection at their hands. And that's why in some hospitals, they will give oral sedation at the beginning, and then they will give the intravenous sedation. So the oral sedation will keep the child a little bit calm and a little bit sleepy, and then they will do the intravenous sedation. Recovery from IV drug is not complete at the end of the sedation session. So usually the child, after even after not only the dental clinic, even from the dental clinic, you will move the child to the recovery. And even after discharge from the recovery, they will not be completely recovered. So they should be accompanied by responsible adult. And usually we give instruction that keep an eye on the child for the rest of the day. And complication at the side of the needle sometimes happen. For example, the vein may rupture or any other difficulty. And it's very rapid technique. And this will lead to what? That the patient sometimes can unintentionally go to the deeper sedation because it's very rapid. So I will give the sedation and the agent, and even before I do my monitoring, I will see that the patient has moved from moderate sedation to deep sedation. And that is really dangerous. And if the child slipped from the deep sedation to general anesthesia, now we are in a big trouble. Because if you remember when we said the definition of sedation, that the child can maintain the airway open and can maintain the breathing by himself, the child can breathe. But in the general anesthesia, the child cannot maintain these functions. And I have to do mechanical ventilation from outside. And in order to do this, I should have an intubation. So if I'm doing intravenous sedation, usually the child is not intubated. So if the child is slipped to the general anesthesia unintentionally, this has a great risk. And the last disadvantage of the intravenous sedation, that the onset is very rapid, but the reversal of the effect is not as rapid as that. So if I felt that the child, I wanted to do only a moderate sedation and the child is now in a deeper level of sedation, and I'm worried and I want to reverse this, and I give the antidote for the child to reverse the action of the drug. Now, reversing the action will take time. It's not like the effect of the primary agent, and this is one of the disadvantages. And therefore, because of all of what we explained in the advantage and disadvantage on the intravenous sedation, it should be approached with caution. Why? Because there is a possibility of progression to deeper level of sedation, and there is a great need for more experienced staff and more advanced monitoring. It's not like the simple nitrous oxide sedation. And there is a possibility of neurological damage or even death. Although these are a rare risk, but it has been reported in some cases in the literature. And you can imagine how devastating it is for the child and for the family and for the community if the child goes to the dental clinic for oral rehabilitation and he dies due to like unintentional deep sedation. And that's why we should approach the IV sedation with very caution. And that's why even if you look in the literature, you will find that the IV sedation is usually used in the developing countries only. They use it as an alternative and more cost-effective way or alternative to the general anesthesia, because the cost of the IV sedation is less than the general anesthesia. And that's why it's used more in developing countries. And usually they use it for multiple extractions. So if you have a child who needs multiple extraction, usually they go for IV sedation. However, the use of IV sedation is getting decreasing more and more in the developed countries because of the risks, the risk associated with the IV sedation. So I hope it's very clear for you. And then we go to another good option, which is the intranasal sedation. You can see the syringe. It's very easy way to administer the agent, the sedative agent, like for example, the midazolam. We just put it on the syringe and we inject it inside the nose. So what are the advantages? Easy of administered. It's very easy to administer. It has rapid absorption because it's very near to the CNS. It has rapid onset of sedation. And usually the parent accept the intranasal sedation very well. And the side effect is somehow acceptable, sometimes only nausea or vomiting, and it doesn't have a prolonged recovery like the IV sedation. So these are the advantages. What are the disadvantages of intranasal sedation? That some children experience distress at the administration due to the low pH of the drug. For example, the midazolam had a very low pH, so when they inject it, it's usually cause burning sensation. And if the child is a little bit heavy, so usually we calculate the dose per kilogram. So if we needed to give, for example, 5 ml or 7 ml intranasal, it's going to be a lot, and it's going to be very annoying for the child. And the other thing that some of the children may regurgitate the fluids, and they either spit it outside or swallow it. And this amount, we cannot measure it. So we cannot give the child again. And that's why the final outcome of the sedation is unpredictable. So these are the disadvantage of intranasal sedation. What about oral sedation and the oral route of sedation? The most well-known thing that it has a universal acceptability, right? Because every parent will accept that you will give the child a drug orally, and even children, even if the taste is not really good, but it's better for them than having an injection at their hands, right? So the advantage, ease of administration and low cost in comparison to other routes of administration, incidence of adverse reaction less than other techniques, and no needle, syringe, or special techniques or equipments are needed. It's just a drug, you're going to give it. But what are the disadvantages? That it is untitratable. So you give your dose, but you cannot, like the IV, look at the child and monitor the response and then decide if you need to give extra or not. It's only one shot, you give it and that's it. Onset and recovery may be prolonged due to variable absorption of the drug. So usually we'll give the child the oral sedation, and we will have to wait, and it's going to sometimes be prolonged because of the stomach absorption. Difficult reversal of unwanted effects. So by mistake, if we calculate the wrong dosage or anything happen, and we want to reverse the action, it's also going to be a prolonged and difficult, because you're going to wait for an absorption. It's not like the IV or the intranasal. And we need the child somehow cooperation, because we need them to swallow it. And usually they cooperate. From clinical experience, usually they cooperate with the oral sedation. And that's why oral sedation is getting more and more acceptable and more famous at the clinic. And by that, we finished the 4 main routes of drug administration. And I would like just to give the clinical, or to explain the clinical techniques that usually we use to do the nitrous oxide sedation, because it's the easiest and it's the safest. And I'm expecting that most of you will use nitrous oxide sedation when they graduate and they work at their own clinics. And the other thing, that for the other type of sedations, usually you're going to need a doctor with you. You're going to need either a technician or a doctor, either a sedationist or a sedation or a general anesthesia specialist. Okay, but for the nitrous oxide sedation, you only need a nurse. You should be trained, and your nurse should be trained, and you can use it by your own. And that's why I believe that it's very important for you to know the clinical techniques. As we mentioned, that it's very simple and very safe, and patient can return immediately to the normal life after the nitrous oxide sedation. However, there is one important point before we explain the clinical technique for the nitrous oxide, that nitrous oxide alone is not enough to do the dental procedure. Yes, it has a minimum analgesic properties, but it's not enough to do extraction, for example. So even with nitrous oxide, you have to give your local anesthesia. If you're going to do a pulp therapy or you're going to extract the tooth, you have to give local anesthesia. Maybe if you're going to do like simple restoration, you can do it with the nitrous oxide. If the child is not impaired, you can do it. But if you are going to the pulp or you are going to extract, you have to give local anesthesia. So what are the equipments you need? You need the nasal hood, and it should be of a good design, and the size should be suitable for the child, because if you are using a bigger size, then the child, there will be a leak of nitrous oxide. You should have a fail-safe machine system with automated shutdown if the oxygen fails below 20%. And usually the machine we usually use, and the one is the safest one, the automatic shutdown will be if it's failed below 50. It's not going to wait until it reaches 20. So from 50, it's going to shut down. and should have an audible and visual alarm, and should have a color coding of gases. So the oxygen cylinder will have a special color, and the nitrous oxide cylinder will have a special color. And why we do have this? Because there is one case reported in the literature. It happened like very long time ago when the dentist switched off the cylinders. So he put the oxygen in place of the nitrous oxide, and he put the nitrous oxide in place of oxygen. And when he opened the gases, he gave more nitrous oxide than the oxygen. And we said that the ratio usually should be in a favor of the oxygen. The oxygen should be more than the nitrous oxide in most of the time of the procedure. And from that time, usually we get color code of the gases, and not only color code, even they have a different handle. So if you try to put the oxygen in the place of the nitrous oxide, it's not going to fit. So it's totally safe now. And you should have efficient scavenger system for your clinic, because sometimes there is a concern about the toxicity for the staff, not the patient, for the chronic exposure of the nitrous oxide. So how can you do it in the clinic? First of all, you start by only oxygen. You put 100% oxygen at the beginning for 2 or 3 minutes. And then you start opening the nitrous oxide gas, and you do it incrementally. So you put 20% nitrous oxide, and the oxygen will be only 80%. And then you wait, and you look at the child and talk to your patient to measure the response or to evaluate the response. And then you increase it by 10. So after 20 nitrous oxide, you increase it by 10, you will have 30 nitrous oxide, and you will keep going mostly until you reach 40 or maximum 50. Okay? Usually, most of the patient, by 40, you will reach the desired level of sedation. The patient will look calm, relaxed, smiling, and he will respond to your comments. Most of them will be laughing, and he will respond to your comments. So open your mouth, he's gonna open. Raise your hand, the child will raise the hand. And by that, you will know that you reach the desired level of sedation. And then you are encouraged to speak to your patient through the whole session. As we mentioned at the beginning, you should keep doing non-pharmacological child management. So you should keep tell, show, and do, explain to the patient what you are gonna do, or tell a story to distract the patient. You have to continue do your non-pharmacological techniques. And then you do your planned procedure. For example, you want to extract the tooth, you give your local anesthesia, and you do your extraction, and then you manage the bleeding and everything. And after you finish, you turn off the nitrous oxide, and you keep the patient on pure oxygen for at least 5 minutes. And why we do that? We want to minimize something called diffusion hypoxia. And diffusion hypoxia usually happens if we turn off the nitrous oxide and we didn't open the oxygen for 100%. And usually the nitrous oxide will just diffuse out of the body quickly, and there will be a lack of oxygen, and that will lead to hypoxia. Okay? And during your whole procedure, you need to monitor your patient to ensure the safety. And the goal of monitoring to detect any potential complication early and to be able to treat it. And in the nitrous oxide, you only need pulse oximeter. You don't need anything other than that. You just take your pulse oximeter, put it on the patient fingers, and that's it, okay? So in conclusion, regarding dental sedation, we should accept and we should know that there is a general agreement that the use of single drug or simple sedation is safer and more advisable than to combine drugs and routes. And the more drug and route you combine, the more risk you are putting your patient on, and the more adverse reaction to happen. So combination regime must be restricted to a fully trained practitioner. And as we mentioned, you need a technician or sedationist with you. And the clinician should realize that there is no recipe book for sedation, and the decision for sedation should be a case dependent. So you should look at your patient, and you should take into consideration all the factors we mentioned, and then you should decide which type of sedation you go. And by that, we finish the lecture of dental sedation. I hope it's useful and easy to understand for you. And if you have any question, we're gonna meet inshallah in the live session. Thank you very much.